evening, respected teachers, my fellow colleagues, and my dear juniors. Today, I'll be discussing a critical and often debatable topic in the management of head neck cancer, that is elective neck dissection in N0 oral cancer. The central issue in managing early stage oral cancer is clinical N0 neck, meaning no lymph nodes are palpable or visible on imaging like CT or MRI. The dilemma arises because despite the clinically negative status, there is a significant risk of occult mets ranging from 20 to 40%. So why is this critical? Because nodal status is the single most important prognostic factor for survival. Survival rates decrease to less than 50% for patients who are node positive. Therefore, we must address this occult disease. We have three main management options for clinical N0 neck. First is the elective neck dissection, where prophylactic surgery is done to remove the lymph nodes at the same time as primary tumor resection. Second is the watch and wait, where we do close surveillance with plan to perform a therapeutic neck dissection only if a node becomes clinically positive. Last but not least is sentinel lymph node biopsy, which is a minimally invasive approach to identify and analyze the first node draining the tumor. The central question which we will explore today is, does elective neck dissection improve survival and regional control? My first piece of evidence is the landmark trial DeCruz and colleagues from Tata Hospital, Mumbai, published in 2015. This was a randomized controlled trial of 596 patients divided into two groups, elective neck dissection and watch and wait group. This study included patients within the age group of 18 to 75 years with diagnosis of T1 or T2 N0 oral squamous cell carcinoma involving tongue, floor of the mouth, buccal mucosa, which are lateralized to one side with no previous treatment history or any past history of head neck cancer. The results measured at 39 months of follow-up showed overall survival of 80% in the elective neck dissection group compared to 67.5% in the therapeutic neck dissection group. Similarly, the disease-free survival was 69.5% in the elective neck dissection group compared to 45.9% in therapeutic neck dissection group. Critically, elective neck dissection had fewer survival overall deaths and fewer recurrences also. A post-hoc analysis suggested that tumors with depth of invasion less than 3 mm may not benefit from an elective neck dissection, which points to the need for better patient selection. This study also comes with some limitations. That is, only 3 oral cavity subsites were included in this study. That is tongue, floor of the mouth, and buccal mucosa. Shoulder dysfunction was not addressed in this study, and ultrasound was the only modality used in the watch and wait group, which is an operator-dependent imaging modality. Following this, we have the SANT study from 2019 by Hutchinson and colleagues, which is a nationwide multi-center randomized controlled trial with meta-analysis and concurrent observational cohort. This study also explored the efficacy of elective neck dissection with 250 patients in the randomized controlled trial and 346 patients in the observational cohorts, including 27 hospitals and 52 surgeons. The risk of occult mets was 19.1% in T1 tumors and 34.7% in T2 tumors, confirming the high-risk population we are dealing with. The intention to treat analysis at the end of 57 months of follow-up showed a trend favoring elective neck dissection with an overall survival hazard ratio of 0.71 and a disease-free survival hazard ratio of 0.66. 20 patients did not strictly adhere to the study program. So 230 patients, taking into account 230 patients, the per protocol analysis was done, which also showed a stronger benefit with overall survival hazard ratio of 0.59 and disease-free survival hazard ratio of 0.56. The locoregional recurrence was also better than the better in this study with a hazard ratio of 0.48. If we look at the forest plots, the meta-analysis for overall survival, including all the previous randomized control trials, here it shows the pooled hazard ratio, that is the black diamond, favoring elective neck dissection group. Similarly, the disease-free survival also favored the elective neck dissection group. But it is important to note that in this study, there was a limitation that the elective neck dissection group had longer median hospital stays and reported more adverse events like sensory and motor nerve abnormalities. To consolidate this, a systematic review and meta-analysis published in 2024 by Takeda et al. Incorporating 5 RCTs was done, which compared in two groups. The intervention group included primary tumor surgery with neck dissection, which may be elective neck or sentinel lymph node biopsy, and compared it with primary tumor surgery alone. The outcomes were overall survival, disease-free survival, local regional control, and harmful outcomes, which included surgical scar, wound pain, and shoulder dysfunction. The forest plots for overall survival uh, and disease-free survival, as well as local regional control, all favored and the intervention group, that is elective neck dissection or sentinel lymph node biopsy, is associated with improved survival and better local regional control. However, when looking at the harmful outcome, the data for shoulder dysfunction shows a pooled risk difference that tends towards the comparison group, that is the no dissection group. So this highlights that the survival benefit of elective neck dissection comes with the trade-off of potential morbidity like shoulder dysfunction. My final piece of evidence is a large retrospective cohort study from SEER registry, that is Surveillance Epidemiology and End Results Registry of United States, published in 2025 by he et al. This study encompassing more than 12,000 patients, including T1 or T2 N0 oral squamous cell carcinoma, which compared neck dissection with observation. The outcomes were overall survival and disease-specific survival, and calculated at 5-year and 10-year interval. The survival data overwhelmingly favored the elective neck dissection group. The 5-year overall survival was 65.4% in the elective neck dissection group compared to 58.1% in the observation group. Whereas the 10-year overall survival was 20.9% in elective neck dissection group compared to 11.6% in the observation group. The Kaplan-Meier curves visually demonstrate a clear separation with neck dissection, especially sentinel lymph node biopsy and selective neck dissection, showing a statistically significant advantage p-value of less than 0.0001 over observation for both disease-specific survival and overall survival. However, this study comes with limitations that it was a retrospective study. Secondly, the issue of over-treatment in an estimated of 70% of patients who would not have developed nodal disease, which reinforces the need for better risk stratification. These evidences lead us to the latest clinical guidance, such as the NCCN guidelines version 5.2025, which suggests that for tumors with depth of invasion more than 3 millimeters, elective neck dissection should be strongly considered if radiotherapy is not already planned. For N0 oral cavity cancers, selective neck dissection at least levels 1 to 3 should be considered. For patients with lesions involving anterior tongue, floor of the mouth, or alveolus that approximate or cross the midline, should undergo contralateral selective neck dissection. Finally, to conclude my study, the elective neck dissection provides significant survival advantage and lower risk of recurrences in N0 oral cancers, outweighing risks in high-risk cases, especially with depth of invasion more than 3 millimeter. Observation should be reserved for low-risk thin tumors, that is with depth of invasion less than 3 mm. Neck dissection should be routinely done for levels 1 to 3. Sentinel lymph node biopsy is an emerging, less invasive alternative, but there is always a room for the future trials, that is prospective trials, advanced imaging, and biomarkers for better patient selection. Thank you.
Okay, now let's hear the argument against. Good evening, Hanson. Am I audible?
Yeah, yeah.
Good evening, all the faculties, my seniors, colleagues, and juniors. I will continue the discussion. As we have seen that there's a constant debate between the electronic dissection and watchful waiting. There's intent of paradigm shift is we see in all everything from radical surgeries to the decreasing minimal surgeries. The watchful waiting with close surveillance and salvage therapeutic neck dissection is a quality of life preserving strategy for a large subset of N0 patients. The main point of that is to avoid the over treatment of elective neck dissection in clinically node negative patients. Uh, as seen in the decrease trial, up to 70 to 80% of patients with clinical N0 were pathological N0, and elective neck dissection was not totally required procedure in such cases. And it goes from the principle of first do no harm, and there was also morbidities associated with different with neck dissections like shoulder dysfunction, chronic sensory changes, numbness and pain, lymphedema, scarring and contour changes in the neck. Also, we have to consider the surgical complications like seroma, infection, cardiac, etc. One systematic review and meta-analysis of the randomized controlled trials comparing elective neck dissection versus the sentinel lymph node biopsy in that was published in 2022 by Tejal Gupta and colleagues. In this study also, there was nearly 20 to 30% patients of having occult metastatic in occult nodal mets in draining lymph nodes. So it did not compare the watchful waiting as such, but it showed that elective neck dissection was unnecessary in remaining 70% of patients. There's one there's one article was conducted in the SMGS Government Medical College JNK, and it was published in 2021. It was elective neck dissection versus watchful waiting in the management of early tongue cancers with node negative neck. Uh, it was there was inclusion criteria included the biopsy proven previously untreated T1, T2 lesions, and the nodal neck was the neck nodes were assessed by preoperative palpation, ultrasound, and CT scan, and exclusion criteria were more than T2 lesion and node positive tumors. All the patient underwent clinical and radiological examination for the neck node assessment with ultrasound probe, and also the probe was used to check the tumor thickness, keeping the probe over the tongue. The 7.5 megahertz probe was used, and patients were divided preoperatively into two groups, Group A and Group 1 and Group 2. Group 1 having tumor thickness of more than 4 millimeter, and Group 2 having tumor thickness of less than or equals to 4 millimeter. Both the groups underwent primary excision of the tumor with safe margin of 15 millimeter, and then Group 1 underwent the selective neck dissection, and Group 2 underwent the watchful waiting. The mean follow-up period was approx 40.3 months for Group 1 and 39 months for the Group 2. The on the after the surgery, on comparison of the histopathological examination of the specimen, the preoperative thickness on the group one, that is more than 4 millimeter. 35 patients were present in the group one, and out of them, 33 patient has the more than 4 millimeter thickness, and in the group two, it was the 100% similar results. So the preoperative ultrasound helped in properly assess the tumor thickness. And after the comparison of the nodal recurrence in the both the groups, the nodal recurrence in the group one, that is selective neck dissection, was also seen in the two patients as compared to the observation group. The six patients developed the nodal recurrence, and in this study, it was concluded that the node positivity was significantly related to the tumor thickness. That is, if the tumor thickness more than 4 millimeter and shows significant higher local recurrence and nodal recurrence. And also it was associated node, uh, with the nodal recurrence that postoperative closed surgical margin was also one of the cause for the same. The major limitation of this was smaller sample size and also compared with short follow-up period. Now for the T. Cruz et al. RCT, Few points to be noted in that study was that the tongue was the most common site for the primary tumor assessed in the study, 85.3% patients. So, as tongue has carcinoma tongue has more chances of skip meds, the possibility of occult meds later on is high. Similarly, majority of the patients were moderately differentiated. There were not it wasn't well differentiated tumors in more numbers. Uh, Along with that, there was 57.7% patients having in the therapeutic group and 30 that is observation group, and 33% patients in the recurrence group were having the recurrence, and it was a very significant recurrence, that is for sure. But for the and 50 deaths were also seen in the elective dissection group and 79 in the observation group. And overall survival was lower in the therapeutic group. But the overall survival was better for the elective dissection group on the follow-up, but it didn't provide the surgical specific survival, as post-surgery patients with positive lymph nodes and positive surgical margins or depth of measure more than 10 mm received adjuvant radiotherapy, which also might have helped to improve the survival. And the similar specific mentions for the therapeutic dissection was not included in the article. In this study, 72 patients out of 243 who had pathological positive nodes in the elective neck dissection group. And even out of that, tumors with DOI less than 3 millimeter had only 5.6% chances of having pathologically positive nodes. So there was lack of benefit of for the elective neck dissection in the tumors with DOI less than 3 millimeter. And only ultrasound was used to screen the patients for the neck nodal positivity, while we could have used other advanced imaging as well. And long-term complications of shoulder dysfunction was not addressed in this study. For the SAND study, the finding of the occult disease in the END group was 25.4%. So 75% patients, there was no actual need for neck dissection. And the nodal recurrence, whichever occurred in the resection only group, it was more related to the poorly differentiated tumors, PT2 stages, tumor margins less than 5 millimeter, perineural lymphovascular invasion, larger tumor diameter, and more more DOI compared to the patients who were alive and had only dissection only. This is one of the table of the SAND study. It clearly shows there's a significant nerve damage and shoulder, face and neck dysfunction seen in the resection with neck node dissection group compared to the only observation group. And this is an overall survival chart showing that it has a better overall survival for the elective neck dissection group, but the p-value was not quite significant. Another study of preoperative predictors of occult nodal disease. It was it was a review article, and it was conducted in USA. Unfortunately, I couldn't get access to the full article of this. And in this, they have taken the review of CT1N0 cases of National Cancer Database, and there were 2,623 patients were included who had occult nodal disease. And in that, the well-differentiated tumors had only 5.9% incidence of the nodal disease, while moderate differentiated and poor differentiated has 17.4% and 28.5% chances of the nodal incidence. There's one meta-analysis of elective nerve dissection versus observation, and that is a systemic driven meta-analysis performed for T1, T2, and 0 lesions. Uh, the conclusion of this study prefers that electronic dissection might be superior than the observation in the early stage tumors, but the same way the uh, in the there was for the local region local recurrence and the overall survival, the significance was p-value was not significant in the comparison. The efficacy of surveillance is very much important, and as I said in decreased trial, only ultrasound neck was used to look for the nodal events. And other advantage of imaging and follow-up are required that ultrasound with FNA can be used, CCT, PACE can be used, PET-CT can also be used in some suspected or doubtful cases for the to decide whether T1, T2 patients having the suspicious lymph node is positive or not. And with that, we can avoid the one approach for the all T1, T2 lesions, and we can divide the patients in low risk and high risk. Low risk having T1, T2 with well-differentiated tumors and depth of invasion less than 4 millimeter with no LVI PNI, and we can plan for the observation in such cases, but we have to have close follow-up for the same. In the to on the intermediate way between the elective neck dissection and watchful waiting, the sentinel lymph node biopsy is another approach which should be used. And other the further future prospects are using the genomic profiling to predict the possibility of nodal metastases and during the observation period. And further study on the role of biomarkers guiding the treatment is also required, and a need for patient factor specific large RCTs. All of these studies were not divided between the DOI of less than 4. Those were only subgroup analyses were only, and not any large scale studies were there. One of the article of role of the biomarkers in early T1, T2, and 0 cases is that it is recently published in 2025 only. And they have seen that there are some biomarkers like neutrophil lymphocyte ratio, platelet lymphocyte ratio, systemic immune inflammatory index, systemic inflammatory response index. These all biomarkers can be calculated, and they can provide an assistive role to suggest, and the higher levels of such biomarkers suggest a poor overall survival and disease-free survival, and it indicates need for elective decision in such cases.
Dr.
Yes,
Deba,
sir. Yes, sir. Yes, sir.
your rebuttal.
Sir, wait and watch followed by therapeutic neck dissection has increased number of positive neck nodes and extracapsular spread than at elective neck dissection. Therefore, salvage necessitates more radical surgery and additional chemo and radiotherapy, resulting in increased morbidity, adverse psychological impact, and treatment costs, sir. No doubt, elective neck dissection has the risks associated with addition of surgical procedure and its morbidity, but it addresses the risk of micromets and occult neck disease, which holds it in higher place than wait and watch, sir.
Sir, we can't just go for the elective neck dissection all the early T1, T2, and N0 cases. As in all the large studies in subgroup analysis, and also we should go for the sub-characterization of the patients, and taking that low DOI or well-differentiated tumors with no LVI PNI. And in such cases, we should also explain the patients the possibility of the both the things that they're going for the elective neck dissection, and also that there are only very 20 to 30% chance of getting the neck mets later on. And so whether they are accepting that for that they are ready for the only dissection of the primary tumor and then for the close follow-up. So it should be tailored to the patient-specific treatment rather than the generalized treatment, and avoiding the elective neck dissection in all the groups, and going for the observation and surveillance in some specific patient should also be considered.
I have a question for
All,
Yash, sir.
yeah.
So he has mentioned that ultrasound is an inferior method of detecting any net nodes, sir. So in the patients who are on wait and watch protocol, what should be the surveillance strategy?
Yash.
Sir, in that study, the ultrasound was used for the preoperative assessment. Preoperative node positivity, not the follow-up, sir. So in that they only used ultrasound. In the DQ trial, they used ultrasound primarily for the pre-op. I was talking about the CCT, PET-CT, and MRI possibility of MRI to decide whether even some suspicious 5 mm node is there, which we sometimes think that is a reactive lymph node. So in such doubtful cases, we can go for PET-CT as well to look for the SV uptake, and then we can rule out it from the observation and surveillance, rather than just going with the ultrasound or CT scan only.
So what
And
should
for
be
the
the surveillance strategy?
Sir, surveillance should be, sir, a close follow-up, as in with initially, sir, every weekly or 2 weekly clinical examinations with every 2 weekly clinical examinations with monthly, sir, ultrasound, and ultrasound is high resolution. Ultrasound is can pick up the nodal mats, and then, sir, 3 monthly, sir, higher imaging, sir.
But for
So
how
Yes.
long, Yash? Yeah, Yash, for how long? This surveillance goes on for how long? How many years? After 3 years, the risk normalizes.
After 3 years, yes, sir. After the most of the neck node mats are seen in the first 3 years, sir.
So after 3 years, what will you do? You will not observe the patient. I mean, you will
No,
not
sir.
follow it up.
After 3 years, I will follow up with routinely the 3 monthly clinical examination, and then 6 monthly, sir, imaging. Decrease the interval between that. Still, it will be more cautious or more aggressive than the routine patient, sir.
Okay.
I have a question as well. If the patient develops recurrence and then you do a second surgery, I mean therapeutic like in the DCRUISE trial, does it affect the survival of the patient?
Ma'am, it has shown that once the patient develops the recurrence, there are the recurrences are definitely having more extracapsular spread, and more chances of the ENE nodes, and so the ultimate therapeutic neck dissection becomes a bit difficult compared to the elective neck dissection. But it is for the, sir, ma'am, generalized patient population. What I was talking about is for the selective some patient population, like
No,
we
no,
should
no.
go
I'm
for.
not interested in what you were saying. I mean, I'm interested in the question. So if the patient you are following up develops a nodal metastasis during follow-up and then you do a therapeutic neck dissection, does it affect his survival vis-a-vis if he had undergone a elective neck
Yes,
dissection?
ma'am. So, the survival of therapeutic neck dissection is comparatively worse than the elective neck dissection.
Then it itself shows that it should not be done in majority of patients.
But ma'am, this comparison was shown for the all the it included moderate differentiated, poorly differentiated patients, and with high depth of invasion patients as well, sir. There
When
was
the
no.
survival rate decreases to less than 50% whenever a node becomes positive node.
Dr. Deba, there is a question.
Yes, sir.
What is the time interval between diagnosing a positive node and doing a salvage surgery in DCRUISE trial?
Sir, there is no such mention about the time interval, sir, but I
What
think
was the
it should,
surveillance? What was the surveillance in his trial?
sir, 39 months, sir.
No, no. How did he do surveillance in his trial?
Sir, ultrasound, sir. Ultrasound was used as a surveillance.
How often?
Sir,
As and
two
when
weekly,
patient came to Mumbai.
sir, 2 weekly surveillance was done, sir.
Imagine a patient running to the hospital every 2 weeks for an ultrasound.
Yes, ma'am.
How many complied?
Sir, as such, all the patient, as per the data, sir, all the patients were strictly adhered to the study, sir. All
So,
596.
Dr. Deba,
Yes, sir.
see, basically when you say at the time of recurrence, when the node is addressed, the
Yes,
node
sir.
becomes ENE positive.
Yes, sir.
So ENE positive node would not occur in a day or two.
Yes, sir.
So doesn't it suggest that the nodes were detected when they become clinically positive?
Yes, sir. Possibly, sir. Sir, but As ultrasound was used, sir, it is an operator dependent technique, so it might be missed when in the previous setting, and it might have taken up by another person.
My question to Deba, is there any data in decrease trial that how much recurrences were there in contralateral neck?
No, it was not mentioned in the decrease trial about the contralateral mets.
There were two RCTs, Dicruz and SEN. So both included T1, T2. What do you think if subgroup analysis done with respect to T1 only, the results would at least be comparable between elective and observation?
As per the SEN trial, the risk of occult tent mets was 19.1% in T1 tumors and 34.7% in T2 tumors. So both these populations are at high risk only. So I think next should be addressed.
Deba,
Any other? Yeah.
in the third study you have mentioned a meta-analysis. Did they compare sentinel lymph node biopsy to elective neck dissection? They are saying one sentinel plus sentinel and one arm is sentinel and elective neck dissection, other is observation. So have they compared sentinel with elective in your third study, that is meta-analysis?
No, sentinel was not compared with elective neck dissection. It was
I think
sentinel or
Yash.
elective. I showed the slide, sir.
Okay, you showed. Okay.
Sir, it was a Takeda et al. Study, sir, from 2024. Sir, there were two groups comparing surgery plus elective neck dissection or sentinel lymph node biopsy, and compared it with surgery alone with no neck dissection. So sentinel lymph node was not compared with elective neck dissection.
I just wanted to know about the shoulder dysfunction, which you have mentioned most oftenly in the study. So, in what percentage of the patients we have seen shoulder dysfunction, and how often this complication is encountered?
It was seen in the 30% of patients in the elective neck dissection in that trial, and it include even it the article mentioned that even if the nerve was preserved, so which was uh, easier, it becomes easier in the elective neck dissection rather than therapeutic. Even after the due to the effect of the scar or compression by they have mentioned that it or the electrical injury, that leads to the post-op shoulder dysfunction.